Hi, everyone, and thank you so much for joining us today. As parents and caregivers of children with neuroblastoma, so much of our focus is on getting through treatments day by day, scan by scan, holding on to the hope of stability, remission, and survival. Survivorship is a phase we all dream of reaching. It's what we fight for, but it also comes with complicated emotions. After living in a world of constant treatment, monitoring, suddenly being without active treatment can be frightening. Many of us find ourselves asking, what now? We're worried about the silence between scans, about not doing something, and of course, we're painfully aware to the risk of relapse. That awareness never really goes away, and it can make the survivorship phase feel uncertain, even as we celebrate getting there. That's why today's session is so important. We are honored to welcome Dr. Lisa Diller, one of the leading experts in pediatric survivorship. Dr. Diller is pediatric oncologist at Dana-Farber, Boston Children's Cancer Center, where she has focused not on just treating childhood cancer, but also understanding and supporting children and families after treatment ends. She has been a pioneer in developing survivorship care plans and researching long-term health effects, and in helping families feel equipped to care for their children into adulthood with medical, emotional, and practical support. Today's conversation is about empowering all of us with knowledge, with tools, and with perspective. It's about understanding what to expect in survivorship, how to advocate on ongoing care, and how to live with both hope and honesty. We're grateful to have you here, Dr. Lisa Diller, for being with us today, and we'll welcome you. We look forward to your presentation.
Thank you so much for that kind introduction. I'm going to share my slides, so just give me one moment to fuss with my internet. Hi there. Everybody see okay? Thumbs up, Einat? Yes? I'm here today to talk about survivorship after high-risk neuroblastoma. And as Einat said, high-risk neuroblastoma is a disease that if you're a parent of a child with that disease, presents multiple challenges during therapy, but also challenges after therapy. I'll hope to get to a few points here today, and if I don't get to any thing that you wanted to hear about, please feel free to add a question to the Q&A box. I thought I'd tell you a little about me and about one of my patients, talk a little about what we know about high-risk neuroblastoma survivorship and what we don't know, and then what I think is important for survivors to know, especially about some resources that are available. So a little about me. I've been a pediatric oncologist now for almost 40 years. And when I started my career, honestly, there were no survivors of high-risk neuroblastoma. We followed one young man in our clinic who was a long-term survivor. The care, there was active chemotherapy. Kids got chemotherapy for as long as it lasted, and then the disease came back. And it was very rare to take care of a child who was a high-risk neuroblastoma survivor. I was a pediatric oncologist interested in solid tumors and solid tumor clinical trials, and got involved with clinical trials for high-risk neuroblastoma, as well as low-risk and intermediate-risk neuroblastoma, and got involved with the neuroblastoma group at the Children's Oncology group, and have spent my career working with my colleagues in that group. But in the meanwhile, kind of apart from neuroblastoma, I started the survivorship program at the Dana-Farber. And there we were seeing survivors of other diseases, which in the 70s and 80s and early 90s, people started to have high numbers of kids who were survivors of Hodgkin's disease, of leukemia. And we developed a clinical program for high-risk neuroblastoma, for other patients. And we didn't have any high-risk neuroblastoma survivors in our clinic. And then over time, that started to emerge as a group of patients that we started to see. I'll tell you about one of my patients. Kay was diagnosed at age 3 in 1994 with metastatic neuroblastoma, and she was treated with therapy very similar to therapy that's still used today, with 5 drugs, chemotherapy during induction, followed by resection of her abdominal mass and local radiation. And then she had a stem cell transplant that included total body radiation. She had a double stem cell transplant where the second transplant included total body radiation. And I took care of her while she was getting her therapy, and then she came to my survivor clinic. And she had an elevated marker of what's called thyroid stimulating hormone, which is an indication that your thyroid has stopped working. It's easily treatable with replacement thyroid. At about age 10, I started to notice that she really wasn't growing as expected in terms of height, and she had no pubertal development. She was started on estrogen and progesterone, and when she was 18 years old, she graduated from college. I'm going to show you a picture of her at her graduation trip to London with 3 of her buddies from, sorry, I said college, I meant high school. She went on to college. So this is after high school graduation, and I think you can pick out my patient because of her short stature, but you can also see that she's independent and socially engaged with her family and her friends. And here she is, a more recent picture at her 30th birthday. And she's done quite well. And it's my hope that those of you who are struggling with high-risk neuroblastoma see your children at their 30th and 40th and so on birthdays as well. So survival from high-risk neuroblastoma has improved from the beginning of my career to now. It's not really 100% clear which features have contributed to that improvement. Transplant with stem cell support definitely was studied in a randomized way and seems to improve survival. Double transplant, the same, studied in a randomized trial. Cisretinoic acid, also known as isotretinoin or Accutane, and antibody therapy, those 4 have been studied as contributors to that long-term survival. But we also don't know whether our surgery has gotten better, our radiation has gotten better, that we've done a better job of doing imaging and using imaging techniques to assign the right people to the right risk group. Figuring out better supportive care, getting kids through the intensive therapy, getting through infections, and figuring out who's truly at high risk. I think all of those things contribute to understanding the statistics that show us that we're getting better in terms of having patients who are long-term survivors of high-risk neuroblastoma. Here you can see the numbers that we started with. So at the very beginning, this is before my time, I was still in high school, start in 1971, or junior high school, I should say. But there were very, very few individuals who survived high-risk neuroblastoma. That's the graph on the left in work published by Audrey Evans, who's kind of considered the grande dame of neuroblastoma research and is responsible for much of our understanding about neuroblastoma staging. And on the right are what we call overall survival curves. So they start at 100% when a person's diagnosed, and then as kids relapse or as the curve goes down, and you can see the blue curve is 1990 to 1994. That's the era in which my patient was treated. And the expectation there was that about 30% of patients might be long-term survivors. The red curve, the most recent one I have, shows that that's gone up to about 50%, and more recent data suggests that it's probably 60% or so. So we've made great headway. As I said, in the survivorship clinic in all those years, we took care of lots of patients who had other diseases. And I'm showing you this picture because it's a stark contrast for me as I think about patients who we treated back in those eras. In that era, these two young women are twin sisters. If you look back at their baby pictures and their pictures from when they were young school-age kids, they looked exactly alike. They were indistinguishable. And here they are in their 20s. One of them, I think you can probably guess which one, was treated for ALL when she was about 8. And she suffered from poor growth, trouble with obesity. Her hair didn't grow back. She has hypothyroidism. She has some cognitive defects. And her phenotype, the problems that she has, were extremely common among survivors of ALL. And it was a syndrome of survival of ALL that doctors like myself were aware of. And over time, ALL therapy has changed largely in response to two things. One, a higher and higher and higher percentage of kids surviving ALL. And two, our understanding of the late effects of ALL therapy. And so now a child diagnosed with ALL will not receive therapy that gives them short stature or gives them hypothyroidism or gives them cognitive loss. And doctors who study ALL have been able to change the therapy for ALL to prevent those late effects. And I think that's the next step in neuroblastoma, is to find therapies that leave our children, make our children go back to the health they would have had they not had cancer. That's my goal for the future. Right now, my goal is to take the best possible care and do good research to help our understanding of high-risk neuroblastoma patients as they survive. So what are late effects? Late effects are any condition that happens to a survivor of a disease that changes their life trajectory in terms of health because of that disease. And that can be from things that happen before treatment, underlying genetic factors, factors associated with the tumor themselves. Those late effects can get worse as people age or can get worse because of certain health behaviors. And then in the box are the ones that have to do with kind of the treatment of high-risk neuroblastoma patients, that they occur at very young age, that there are definite effects of the treatment itself, or there are definite events during treatment itself that might contribute, like a severe pneumonia or a surgical complication. And then there are multiple treatment factors that contribute to the risk of late effects. So what my colleagues and I have been doing over the past few years is a study about late effects in high-risk neuroblastoma. The study is called the LEARN study, and you may have heard of it or maybe even participated in it with your child. As I said, more than 50% of children with high-risk neuroblastoma are expected to survive. But most data that we have before the LEARN study report really on one organ system. What's the risk of hearing loss, for example, or involve outcome in a single center. And many of these studies that are available include mostly patients who receive total body radiation as part of their treatment, which isn't used very often anymore, largely because of the known late toxicity in survivors. So we thought it would be important to sort of create a modern cohort of high-risk neuroblastoma patients. So LEARN is a children's oncology group cross-sectional study, which means we looked at patients only once. They were eligible if they were 5-year survivors of high-risk neuroblastoma diagnosed at a COG institution. COG is the Children's Oncology Group, or the cooperative group in the United States. And our goal was to understand the burden of long-term toxicity in terms of prevalence, or how often certain late effects occur, what risk factors there are for late effects, what the impact of those late effects are on quality of life, and to collect biologic specimens so that we could understand risk factors for those late effects. The patients were identified by the Children's Oncology group. The parents or the patients, if they were old enough, gave consent, and then the patients underwent specific study procedures. Like I said, we wanted patients who were treated relatively recently. It seems like a long time ago now, but after the year 2000, when people stopped using total body radiation, patients had to be at least 5 years from diagnosis and at least 2 years from chemotherapy. They were allowed to have had a relapse, however, so we have some information on patients who suffered a relapse. They were consented by their local doctor, and then they underwent a number of studies like audiograms, heart studies, echocardiograms and EKGs, bone age, dental exams, pulmonary function studies, medical exams, and laboratory evaluations. We took significant and deep histories and physical exam data to help us understand some of the risks. And then we asked the parents to fill out questionnaires about quality of life, demographics, and family history. And all the medical records were abstracted. We enrolled 375 high-risk neuroblastoma survivors. This feels to me like someone in my career who's kind of like been at it for a long time. To have information on 375 high-risk neuroblastoma survivors is a testimony to not only the doctors and scientists who have been working on high-risk neuroblastoma for a long time now, but the parents and patients themselves. The median age at enrollment in the study was 12 years of age, and the median time from diagnosis was 9 years from diagnosis. Median means half of the children were above 12 when they joined the study, and half were below 12. Their treatment was pretty consistent with what we would have expected. Almost everyone got chemotherapy, and almost everyone got high doses of chemotherapy of a subclass called platinum analogs. Almost everyone got at least one transplant. 64% got antibody therapy. 20% had 2 transplants. 9% had MIBG therapy. 91% got cisretinoic acid or isotretinoin, and 95% had radiation to their tumor site. 20% or so, and 19% had a history of prior relapse. What we found, I'll show you on this graphic, just to sort of give you the overall, is that there was a large burden of late toxicity in multiple organs in these patients. About 88% had hearing loss of some kind. Almost 60% of those required hearing aids. 17% had hypothyroidism, and 5% had thyroid nodules. Prediabetes or diabetes occurred in 7%. Growth hormone deficiency in 12%, and severe short stature in 24%. Those are the endocrine toxicities. One more endocrine toxicity is premature ovarian failure. In the girls who were greater than 8 years old, about a quarter of them had evidence of early failure of their ovaries. In terms of kidney function, about 7% had abnormal kidney function, and 6% had hypertension, often because of kidney function. In terms of cardiopulmonary health, a small percentage had these severe consequences of therapy, restrictive lung disease, congestive heart failure, or pulmonary hypertension, which is when the vessels that bring blood to the lungs are under hypertension, which can result in the heart, the right side of the heart, which pumps to the lung, being damaged. And about 4% had a second malignancy. This is what's called a Venn diagram, kind of showing the overlap between how many late toxicities people had. The big circle there is hearing loss, showing that 200 people had hearing loss in this cohort that we measured. And then those other circles are overlapping. So hearing loss plus second malignancy, hearing loss plus restrictive lung disease, hearing loss plus growth failure. So you can see there's only one patient who had all 4, but a large number that had more than one. interestingly, there were 57 people who had none of these late effects. And we are going to do more work to figure out if there's any underlying biologic reason or resistance, resiliency in some way physiologically that tells us what goes on with those kids. So this becomes important research information. Now I'm showing you a height distribution. What you're seeing here is a growth curve. And if you'll just look at the dotted line, this is the normal growth curve. And it's normalized, meaning that the middle of the growth curve, or the median height in a population, the 50th percentile, sits at 0. That's the way they normalize it, so they can take into account the age of the patient. So this was if you got a therapy and took 375 people who got that therapy and followed them for a median of 9 years and measured their height, and the therapy had no effect on height, their growth curve should look just like this. But the growth curves we're observing in our patients are shifted way to the left, meaning that after a single transplant, here's the distribution of the growth curve. So the median of the growth curve is about 1 standard deviation lower than the population. Probably the more important way to think about it is if you get to -2, that means you're in the bottom 5% of height. So you're shorter than 95% of people. And these kids in the blue and the red are sort of in that age range. And then at this end is that severe short stature. The tandem transplant patients, there were fewer of them, so the curve is sort of lower because we just have fewer observations. But you can see that the curve is shifted even further to the left after tandem transplant. Now, height's an interesting thing, right? Because, you know, there's short people everywhere in the world, and there's ways to deal with it. Sometimes we talk about it being harder for boys than girls. I think about in feet. So excuse me if you think in centimeters. But, you know, for a boy to be less than 5 feet tall can sometimes be a difficult proposition. Some of our patients are treated with growth hormone with variable effects. This is not just a growth hormone deficiency problem. The other thing I wanted to mention, because they weren't on my previous lists and charts, is that our patients who are long-term survivors have benign tumors. They show up because we do scans on them, but they are not life-threatening. Those include thyroid nodules. Those include little bone growths called osteochondromas, little liver growths called fibronodular hyperplasia, and they sometimes need to be followed for a little bit. Osteochondromas can cause pain, but in general, these are not difficult or life-threatening problems. The other thing I didn't mention, but are pretty common among survivors, are dental problems. The risk factors include intensive therapy, young age at diagnosis, and radiation therapy to the area. Neuroblastoma survivors have been described to have a variety of adverse dental outcomes, including missing teeth, small teeth, short roots, dental decay, and need for treatment of dental caries and discoloration. We have dental x-rays from the members of the Learn cohort, and we're trying to get the funding to have a dental researcher look at them and really report on this. I bring this up with parents because if your child needs braces, it's really important to make sure that you have an expert pediatric dentist take a look at the dental x-rays called the Panoracks. A lot of the ways braces work to straighten the teeth is they put a brace on that uses the back teeth to kind of pull on the other teeth. And if those back teeth don't have long enough roots or are misformed, the braces can be harmful or not work. So we really encourage our parents of survivors to make sure they get an expert thinking about orthodontia before they go ahead with it. Another thing that we collected in the LEARN study was a lot of information about quality of life, adjustment, emotional health. We're again analyzing that data at this point. I bring up just one tiny piece of it because it interfaces with some of the hearing loss information. About 60% of the children who were in our cohort participated in a special education program. Most of them because they needed special education services because of hearing loss. Only a small percentage needed to repeat a grade despite having multiple medical problems, despite many of them having hearing loss. So I think in general, they do quite well in terms of schooling. But there's so much we don't know. We are going to be following our new cohort, which is going to be called the Learn 2 cohort, longitudinally as opposed to cross-sectionally, so we can understand better the risk of late relapse. I know that's something that Anat mentioned in the introduction as something that worries parents the most. Thankfully, we don't see a lot of late relapse, but when we see them, I know a wave of fear sort of goes through the community of both doctors and parents thinking about that patient that they knew and thought was cured. We also don't know a lot about the outcome from relapse therapy. So not only don't we know about late relapse, we also don't know if a patient relapsed early and then had good and effective therapy and became a long-term survivor. We honestly don't even know if those patients have a higher risk of late relapse than patients who never relapsed at all. There are a ton of new agents coming down the pike or have been used that we still need to learn more about. Retinoids have been said to have outcomes associated with joint and bone growth, and we were unable to look at that in our study because almost everyone got retinoids, but hopefully there'll be future studies that we will be able to look at that. There are multiple different immunotherapies, and long-term effects from immunotherapy need to be studied. As an aside, and what I did not mention about the LEARN study is that we found no concerning late effects associated with exposure to antibody at all, that they did not contribute to the late effect profile at all. I'm sorry, I forgot to mention that. The late effects of single versus tandem transplantation need to be fully elucidated. Right now, we have some concerns that tandem transplantation contributes to that increased risk of growth failure, as I showed you on those growth curves. And what if we could get rid of transplant? Wouldn't that be great? And what would the late effect profile be for that? Exposure to MIBG scans and to therapeutic MIBG, we don't know the late effects associated with that. ALK inhibitors, which are given to patients whose tumors show aberrations in the ALK gene, and we don't have late effects data on that, although that appears to be associated with poor growth, weight gain. There's some concern about learning. DFMO, which is a newly FDA-approved drug in the United States, which is given to patients after they complete all other therapy for 2 years, is associated with hearing loss, which is reversible and a different quality of hearing loss than the hearing loss that the patients get from cisplatin. But we don't have any late effect data on that. Many of our patients have had proton beam radiation instead of photons, the older form of radiation, and we're hoping to see a better or a less worse late effect profile after proton beam radiation. And then as new agents come along, we need to study those. So we're putting together the next cohort. And then, of course, we want to know what happens over time. And most importantly, we want to know, just like in ALL, what late effects can we avoid by changing care now, therapy now, and by better care of survivors. And then these children are going to be teenagers and they're going to be adults, so we have to teach them how to care for themselves. And finally, we have our genetic data to help us understand who gets late effects and who doesn't. So in the community of pediatric oncologists, we talk a lot about changing therapy as we look at this spectrum that we saw in the LEARN study. One of the questions that come up is, given the success of chemoimmunotherapy, the combination of chemotherapy and immunotherapy, could we get rid of transplant? Would that be okay, or would we end up with fewer children surviving? And that's a topic of great discussion and something that we are talking about as neuroblastoma clinical trialists in the Children's Oncology group. The parent input into that question is exceedingly important. Yeah, I think that's we can talk about that afterwards. And then can we get rid of some or all of the most hearing loss associated drugs? Can we substitute out some of that platinum-based drugs that we give, since we know it's going to cause platinum-induced hearing loss? And we, in fact, have a trial where we think we might be able to prevent hearing loss using an agent called a statin, which in adults has been shown to prevent hearing loss among adults getting platinum containing chemotherapy. So we're going to be trying that in kids. So where do you go from here? I do think it's important to get good survivorship care after high-risk neuroblastoma because of the wide array of late effects, and that the risk doesn't plateau with aging. There may, in fact, be a clinically silent period for many late effects that we haven't even measured yet, like secondary cancers. And some of these late effects are potentially modifiable by prevention and early diagnosis or intervention. So it's very important to stay on top of this information. Modifiable outcomes include an underactive thyroid, which can be detected with screening, MIBG therapy, MIBG scans, and radiation can all cause underactive thyroid, and that can be detected with an easy blood test and can be treated with a medication. Cardiac disease, in particular, if the heart valves or the vessels were in the radiation field, or the patient got higher doses of a drug group called anthracyclines, which are adriamycin, doxorubicin, and that can be found by doing echocardiograms and adhering to a healthy diet and exercise. In the setting of chest or abdomen radiation, there are risks for breast and colon cancer. This doesn't happen until these kids are adults, and they can undergo early detection with screening. Physical activity and proper diet can ameliorate some of those risks. And diabetes, when the pancreas is an intra-abdominal organ, and many children with neuroblastoma have primary tumors in the abdomen where the pancreas is in the field, we can do testing for prediabetes, and then again make sure that children are staying active and having a proper diet to avoid prediabetes or diabetes. It's really important to plan for lifelong risk-based care. There are multiple resources for that. The links are shown here. The one I use as a North American are the survivorship guidelines put together by the Children's Oncology group. You can go to survivorshipguidelines.org and go to this rather intimidating and long document. It's a PDF that lists kind of every chemotherapy received by children, every field of radiation, and what the potential late effects are, including the available literature, what the risks are, and what the mitigating factors might be. I'll show you an example here is the page that goes into the risk of ovarian failure in a person who got a class of drugs called alkylating agents, which high-risk neuroblastoma patients get. It's kind of hard to read and to get through even for docs, but there is a nice part of it. There's a link which you can also find on the homepage, survivorshipguidelines.org, which gives it in plain English and Spanish about how to think about a specific late effect. There's the list of late effects that have health links, how to think about it, what the relationship between a specific treatment and a specific outcome is, what to do about it, etc. Sorry, need to change the field. So I suggest the health links. Feel free to browse through the guidelines themselves, but know that they were written really as a resource for pediatric oncologists and others who take care of survivors. So I apologize for some of their density and difficulty getting through. I recommend the health links. And then here's a short checklist for your child as he or she becomes an adolescent or young adult. Do I know the name of my cancer? So that if your child ends up in the college health infirmary and wants to give their history, they may not remember having neuroblastoma, but they should know the name. Do I know the names of my chemotherapy, that I got radiation, that I had surgery? Do I know the risks associated with my diagnosis and treatments? Do I have a healthcare provider who's familiar with my cancer history? As a long-term survivor, how do I keep healthy? What screening do I need for late toxicity? And do I need preventive health interventions? The one I mentioned here is hearing aids. Children and adults who, or in adults who have hearing loss and don't wear their hearing aids or don't know they need hearing aids, that contributes to cognitive decline. Children who have hearing loss and don't wear their hearing aids have school difficulty. So I consider that a preventive health intervention and highly recommend that children have hearing tests and figure out a way to get them to wear their hearing aids so that they can be as successful as possible. So in summary, neuroblastoma survivors face lifelong long-term risks. Many of the late effects are modifiable, and the goal of risk-based survivor care is to reduce morbidity and mortality, to educate and empower survivors and their families, and to enhance their quality of life. And I thank you very much for your time and for listening, and I'd be happy to answer questions. Okay, so I am opening the Q&A. And then, so the first question is, while very few had to repeat grades, were there delays in starting school? You know, honestly, I don't know the answer to that. I bet it's in our data and I can find out. So thank you for the question. That is probably a question that we asked every parent, but I have not pulled the answer to that question out. How many years post-treatment are considered late relapse? In general, in pediatric oncology, we use the 5-year mark as a mark of a kind of a period of time in which we might not call it a late relapse. After 5 years, we'd probably call it a late relapse. There's no deep and hard definition, and it depends upon the disease. There are some diseases, not neuroblastoma, where if the disease doesn't come back in the first year, it's probably never going to come back. There are others where there's kind of more, a slower accumulation of early relapses in the first 5 years, and then after 5 years, we call it late relapse. What are the most common and successful treatments for late relapse? That's a difficult question too. I think that one of the most common things to happen in late relapse now are for kids who did not, or young adults who have a late relapse who never received immunotherapy, to receive immunotherapy, because you try in late relapses to include drugs that the tumor hasn't seen before. The other thing that I think is very important, it's not really an answer about treatment, but it's an answer about what we do now versus what we didn't do 5 or 10 years ago, which is doing deep genetic dives into the tumor itself to understand the genetics of the tumor and then tailor therapy to the genetics of that tumor. Often at a time of late relapse, there's an acquisition, or sometimes there's an acquisition of a mutation in the tumor itself that's driving that tumor. And sometimes there's a drug that will interrupt the action of that driver, of that factor. Why is COG still doing transplant when MSK has seen success for years without doing transplant? That's a very difficult question to answer. The MSK has not done a randomized trial transplant, no transplant. The COG, before the COG, the CCG did a randomization of transplant versus no transplant and found a clear improvement with transplant. After that, the COG did a randomization of 1 transplant versus 2 transplant and saw an improvement in outcome with 2 transplants. I don't really know why they see differences at MSK. It may be because of the selection of the patients who go there. It may be for other reasons. They have had a history of using immunotherapy longer than the COG and the CCG have, and perhaps the use of immunotherapy over the years that COG was doing transplant contributed to the success of Memorial Sloan Kettering. This is a question that the COG hopes to answer in a randomized way. The next question is, from which institutions did you pull participant data from this study? In order to be eligible for this study, the enrollee needed to have been enrolled on a study called the Neuroblastoma Biology Study. So that was a COG study for all children with neuroblastoma, to be able to look at their tumors for specific genetic factors like NMIC amplification. And in order to go on to the Survivor study, you had to be enrolled on that study. Now, there are patients who enrolled on that study and did not get COG treatment. So you didn't have to get COG treatment, you just had to be in that initial intake period with COG. The next one says, thank you, Dr. Diller, for the incredible amount of work you've done on this topic over the years. When can we expect the LEARN study results? LEARN study isn't even funded yet. We have weekly conference calls about putting together a research study. As you're probably aware, in the States right now, research funding is kind of a little all over the place, and we're looking at the best mechanisms for getting this study funded. So I don't think we'll see LEARN 2 results for quite some time. Fertility solutions prior to treatment is becoming more of a part of the conversation at diagnoses. Oh, I'm so glad you brought this up. Can you address that in your practice? Egg freezing and sperm preservation are normal these days post-treatment. Yeah, I forgot to bring that up. You're absolutely right. Most of our children at the Dana-Farber and Boston Children's who are going to receive high-risk neuroblastoma therapy as well as other therapies meet with a nurse practitioner whose training is to discuss fertility options. For girls, that's usually harvesting of a piece of ovarian tissue before treatment begins and freezing that ovarian tissue. For boys who are mostly too young to produce a sperm sample themselves, they can undergo a testicular biopsy, which is just basically taking a piece of testicular tissue and viability freezing it so that it can be perhaps used to make sperm in the future. Ovarian tissue preservation is a proven technology and has been used in order to result in a successful, healthy pregnancy. Frozen testicular tissue used to fertilize eggs and having healthy pregnancy after that, to my understanding as of today, has not been proven in humans. It's been proven in animal studies. It's expected to work, but most of the kids who've gone through that have are not old enough to have used their sperm. The other thing that I tell patients is that these very young children are living in an incredible era of medical advances, and I would be surprised if in the future, when they're ready to have children, there won't be other ways to obtain a sperm or an egg, meaning the DNA that a sperm or an egg contains, to de-differentiate a cheek cell, have it only have the right amount of sperm or the right amount of chromosomes to fertilize an egg or a sperm. Like that, the technology is moving so fast that I do think there'll be better ways to do this in the future. We do recommend for girls who are exposed to the kind of agents that that they're exposed to in high-risk neuroblastoma and are long-term survivors and teenagers to consider egg freezing, because they are, if they're having cycles, they're at risk for early menopause in their 20s or 30s rather than 40s or 50s. And so that way they will have those eggs if they want to get pregnant. There should be no trouble unless there's been direct pelvic radiation in carrying a pregnancy. And then post-treatment sperm preservation can be done. It's probably not necessary if a boy has sperm after treatment for high-risk neuroblastoma. There's no evidence that his sperm count will go down over time, so he should consider himself fertile. There's no harm in freezing sperm, though. Should survivor children be on any special diets, organic? I don't really know. I think that we worry about emotional health and physical health at the same time. And as a parent, you're doing the balance of helping your child make good choices around what to eat. I can't comment on anything a overall survivor child should or shouldn't eat. In the setting of obesity or other signs of pancreatic insufficiency, a high hemoglobin A1C, prediabetes, there probably would be recommended special diets. Same if the child is measured to have hyperlipidemia or high blood cholesterol. I think that there's nothing wrong with seeing a nutritionist and getting some better answers than I just provided. The other links, along with the survivorship guidelines, I can definitely provide them. I think this video will be put in YouTube, and you can go to that part and find those other links as well. I would like to learn more about hypertension. Usually, when would that start getting better or worse over time? Great question. Some kids with neuroblastoma present with hypertension because the tumor itself is pressing on the vessels that regulate blood pressure, or in the kidney themselves. Kids who develop hypertension during therapy may get better once the therapy is done. If a child develops hypertension after therapy, it can happen anytime. Usually, I would guess, this is more of a clinical guess than based upon data, that hypertension is common in the general community, people who never had cancer, in their 40s and 50s, people to become hypertensive because their kidneys just aren't working quite as well. Their vessels are just a little bit more stiff. My guess is that process that happens as people age, that early aging happens earlier in kids who are treated aggressively for cancer. So I would sort of worry about the diseases of aging, like hyperlipidemia, hypertension, prediabetes, to start worrying about those instead of waiting to your 40s, like most people do, to think about it in your 20s, and to get your primary care provider to think about it, because they think about mostly healthy 20-year-olds and not 20-year-old survivors of childhood cancer. What can we do to support survivors who have lost one of their adrenal glands? The other adrenal gland should be fine. Wear your seatbelt, I think, is probably the most important one. Maybe avoiding very, very extreme sports, because I think the loss of the other adrenal gland would be highly unusual, unless a tumor developed in it, which would probably be an unrelated tumor later in life, or an injury. So wear a seatbelt. I would say that's probably the most important thing. Is there any data for long-term side effects? Those who didn't follow the COG protocol, for example, my daughter was treated at Memorial Sloan Kettering. She didn't do tandem transplant. It's a great question. My colleague, Danielle Friedman, does the survivorship clinic at Memorial Sloan Kettering and sees many of the survivors at MSK. We're trying to design Learn2 to include the MSK survivors so we can do some comparisons. I think I would consult with Danielle Friedman directly around your daughter's specific side effects. How important is it for a young adult to be involved in long-term survivorship clinic? Can an internist aware of times for, so the question now is, can an internist aware of screening times for cardiac, lung function testing, et cetera, be adequate on their own? I don't know what country you're in and what your healthcare system is like. In the United States, most primary care providers are under an extreme amount of pressure and seeing many, many patients. They're unlikely to have more than one or two survivors of all childhood cancers in their practice. So they are unlikely to be aware of the needs that particular child, especially if it's a complicated one like a high-risk neuroblastoma survivor, has. I think internists are increasingly aware of things like survivors of Hodgkin's disease, for example, maybe survivors of Wilms tumor, where the therapy, the disease is either more common, like a Hodgkin's disease, or the therapy is less associated with a whole bunch of late effects. I think it's hard for high-risk neuroblastoma. I think if it's well written out with a good advocate, like a parent or an engaged patient, I don't think it's impossible to make a schedule and keep up on it, especially if you're geographically separated or from where you might get a survivorship clinic. It's also important to come to meetings like this to learn more things. My job as a pediatric oncologist, taking care of long-term survivors of high-risk neuroblastoma, is to keep up on the data. So you want some way of getting more information as the information changes. With secondary cancers, is there a risk that children cannot be treated due to lifetime maxes of chemotherapy, radiation, et cetera? Is there such a thing as a max dose? Yeah, there are max doses to the spinal cord, for example, that radiation oncologists will always be careful not to over-treat the spinal cord, because damaging the spinal cord obviously can cause problems. Women who've had radiation-induced breast cancer and the treatment recommended might include radiation that a radiation oncologist would think long and hard about, depending upon the radiation dose that the child got previously. It's important to note that most dosing of radiation in high-risk neuroblastoma is rather on the low side of the range of radiation. So there is kind of room to move because there are other diseases that we treat in childhood where the doses are 3 or 4 times higher. And then you asked about max doses. There is kind of a max dose of one of the drugs that we give, the anthracycline dose, or adriamycin doxorubicin. So it's important to know what total dose your child got prior. Someone asked, further options for persistent MRD from the past 16 months, lighting up MIBG scan, PET negative, area involvement maxilla. Oh, I'm sorry that you're going through that. I think that I don't know enough to give medical advice about that. So I think I'm going to bag on that, and you're welcome to send me an email. It's just, it's kind of giving you direct medical advice. I don't think that would be fair. Vicky Inglis says, really interesting. Thank you, Dr. Diller. In the Learn study, you say 57 patients didn't have any late effects. What happens next in the field of research? That will be so much to learn from this cohort. Yeah, I want to be clear about that. 57 patients didn't have any of the 4 ones that were listed on that Venn diagram. So they didn't have hearing loss, they didn't have growth failure, they didn't have a second tumor, and they didn't have restrictive lung disease. So they may have had other late effects, but those are the biggies that they didn't have. And yeah, it's going to be really interesting to figure out what contributes to that. Can you please share the current rate success of CAR T-cell therapy in cases of early relapse, particularly for pediatric patients? For high-risk neuroblastoma, I think the data are case reports so far of, except for the study that was done in Italy, which I'll refer you to. You can get the data directly. It has a good nickname. What's the good nickname? Anyway, it has a good nickname, but it's a study done in Italy, which was a CAR T cell study that actually has a rate of success rate of therapy. The rest of them are pretty much like single cases, double cases. So I think I would defer on that as well. You may have mentioned this, but is there a notable relationship between age of treatment and the long-term outcomes? That's really an interesting question. We thought we would find worse outcomes in the patients who were treated at the very youngest ages, and we didn't see that in terms of short stature or hearing loss. We didn't study it yet in fertility, so I can get back to you on that. I don't know why that is. It's a little surprising. It may be that doctors treating those very, very young patients, less than a year of age, maybe they cheated a little bit on the therapy. By cheated, I mean they were worried that this is such a young baby. I better not give as high a dose of X, or I better not use quite as much radiation because it's such a tiny little baby. The other thought we had is that maybe with really little babies, when they're getting treated, they get G tubes and nutrition, and we don't wait or rely on the child to eat for themselves, so that the supportive care in terms of nutrition is better. So maybe that contributes to better growth. It's really hard to make a 2-year-old who doesn't feel well eat, but maybe that's why, or a 3-year-old or a 4-year-old, but maybe that's why we see so much short stature in those kids. I think we're out of time. Inat, what's your suggestion?
If you can take one more last question, and then all the rest we can attend later.
I think I'll take this one. What can you tell us about intermediate risk survivors? So I didn't focus on that. I am very proud of the work that's been done globally by pediatric oncology clinical trialists to address intermediate survivors, because again, at the beginning of my career, almost all what we call intermediate survivors got radiation and were at risk for secondary tumors from radiation. They got high doses of anthracyclines, the drugs that cause heart disease. They got high doses of platinum agents. And over time, we've been able to come up with a regimen that uses so little of every single drug that none of them are at high enough dose to cause a whole lot of late effects. And we almost always avoid radiation. So we have excellent outcomes in intermediate risk survivors with a very favorable survivorship kind of outcome, if you will. A survivorship outcome in that population. So I think that's been a great advance. And it helped us to, as I said about radiology, to really know who's an intermediate risk patient.
Okay, thank you so much, Dr. Diller, for your time, for your insights, and for your deep commitment to supporting survivors and their families. I mean, this session today gave us not only important knowledge, but also reassurance that we're not alone in navigating this complex reality of survivorship. So thank you so much. We really appreciate it. As we look ahead, I'd like to warmly invite you to join us on our annual Shir for Life Gala taking place in November in New York City. This will be a meaningful event dedicated to honoring children, our children, raising awareness and accelerating neuroblastoma research. Would love for you to be part of it in any way you want, by attending, by sharing your family story, connecting with potential sponsors, or supporting in any way you feel is right for you. Your presence and partnership can help and make this event really meaningful and moving for success. Finally, we hope to see you again on our next webinar on September 5th, featuring Dr. Lucas Moreno, who will share the clinical update of the SIOPEN, the European group. So hope to see you there. Thank you again for being with us today, and have a good one.